Mustafa is a well-known Iraqi reconstructive and peripheral surgeon. He's from Basra Medical College in Iraq, and he's going to talk about case presentation about urethral wall injury.
It's my pleasure to be here to present one of interesting cases. This is from our city, Basra, south of Iraq. I'll talk case presentation, which is radial posterior arthroplasty for blast urethral injury. Okay. Unfortunately, we have a lot of wars and problems in Iraq, so we have a lot of patients with blast and bullet injuries that cause trauma to posterior anterior urethra. In this case, the patient is 38 years man, was exposed to blast injury in 2010, and he had multiple perineal at that time and pelvic injuries that result with multiple shells in the pelvis and perineum, resulted in posterior urethral disruption and ended with suprapubic cystostomy. In 2015, posterior arthroplasty was done outside Iraq, but unfortunately the procedure was failed. Kept on suprapubic cystostomy till 2024, which is the time of radial urethroplasty in March. The urethroplasty was done. The operation time was about 2 hours and 20 minutes. Blood loss about 500 cc. Catheter kept for 28 days. RUG amphometry done 40 days after removal of the catheter, and patient followed for 7 months. This is the preoperative up and down cystourethrogram. We can see that the shell that's present in the perineum and widely separated the bladder neck from the urethra, the bulbar urethra. This is the post-operative retrograde urethrogram. We can see the urethra is well done. The suprapubic cystostomy is not present there. And in between, now I will play the video of the surgery, the major steps. The wide and long segment lost from the posterior urethra separated the bladder from the Now this is the scar of the previous surgery and the previous perineal injuries. Definitely such patients have a lot of fibrous and scar in the perineum from the trauma and from the previous surgery. Mobilization of the bulbar, definitely the proximal bulbar urethra, which is injured from the anastomosis of membranous urethra. You know, the perineum is highly vascularized area, so excision of the bulbomembranous segment with resection of the urethra from the site of the obliteration. This is the proximal urethra. Now the cystoscopic assessment of the proximal urethra is very crucial and important step, because we should be sure that this is a urethra, not a fistulous tract. So the veramentanum of the prostate should be there, as shown in this stethoscope. Now, because I have no space and all the area is fibrosed, so inferior pubectomy should be done to make the anastomosis tension-free. Part of the inferior pubic gland sometimes also resected. And all the fibrous tissue in between should be resected completely to ensure mucosa to mucosa anastomosis. Removal of the fibrous tissue. Until a pliable apex of the prostate with pliable mucosa appears.
Hazara getirtiyor.
This is part of the symphysis pubis. Definitely the corporal are separated before the pubectomy, as shown here.
Traumatic.
Now pliable mucosa is visible here from the proximal segment. Now anastomosis of the urethra with the apex of the prostate. To me, I did version stitches on 4 sides for the proximal segment before anastomosis and spatulation of the distal segment. Very important to make it tension-free. And the catheter introduced after anastomosis. RUG done 40 days after anastomosis. The patient, this is my first teacher, Dr. Ali, present here.